Good morning, everyone, with a monthly peripheral endovascular webcast for Mount Sinai Heart. We are with you every fourth Wednesday of the month. Therefore, the next one is going to be on April 25th. And today the subject is subclavian stenosis, high-grade subclavian stenosis proximally to a patent LIMA that has been used as a coronary artery bypass graft. I'm George Dangas, and in the Catheter laboratory we will have Dr. Krishna and Dr. Wiley and also Dr. Ferris. May I ask you to please send us any questions at the info@peripheralvascularinterventions.org, or you just click at the bottom of the button of the live case screen that you see now, and you will see an email button. You just click and send any question that I would be happy to answer, or ask the operators to discuss about it and address it during the live case. Let's go to the cath lab OR now, and Dr. PK, Dr. Krishnan is there to brief us with the case of today. Good morning, PK.
Good morning, Dr. Dangas. How are you? Again, I'd like to welcome you to the cath lab here at Mount Sinai Medical Center. It's really a great pleasure to be with you again today and really show you an exemplary case of subclavian artery intervention. As we know, as cardiologists or just basically caregivers of vascular disease, aorto-osteal subclavian disease is quite common. And we have a great case that's really pertinent to the cardiologists out there on a patient who has extensive anterolateral ischemia. I'd like to introduce our team here in the cath lab first. To my right is my colleague, Dr. Wiley, who's the Associate Director of Endovascular Intervention. To his right is Ray Lascano, our cardiovascular nurse practitioner. And to his right, we're really happy to welcome Dr. George Fernane, who's a great supporter of the cath lab, interventional cardiologist, who does all this vascular and coronary interventions here at Sinai, and is going to present our case to you. So with further ado, we're going to get right to George.
Good morning, everyone. This is a 66-year-old female with a history of coronary artery disease. She had a coronary bypass surgery, including a LIMA to the LAD. She presented as an outpatient with typical class 3 angina and moderate ischemia of the anterior wall. During coronary angiography at an outside institution, she was found to have a significant left subclavian stenosis of approximately 80%, with a 100 mm pressure gradient. Her surgical history only included the CABG. She doesn't really have a family history. She was a prior tobacco smoker, no known drug allergies. Her medications include aspirin, atorvastatin, metoprolol, lisinopril, and also does include amlodipine, which isn't listed in front of you. On her physical exam, her right blood pressure is about 190/60. On her left, it's 92/65. Pulse is 68. She's, of course, alert and oriented. She has a 2 out of 6 systolic murmur, no S3 or S4 gallop. Her lungs are clear. Abdominal is soft. Good bowel sounds. In extremities, no edema, and she has decreased pulses in the left radial artery, about +1. And her labs and other findings are essentially normal.
Great, thank you so much, Dr. Fernane. So as Dr. Fernane presented, you saw Dr. Dangas, a very, very typical case, and I just want to tell you part of the workup that we did. We went ahead and discussed this case with Dr. Fernane earlier on in preparation for what we were going to do live for you guys. And part of the workup that we did was Dr. Fernane got a CAT scan angiogram. So when he got a CAT scan angiogram, we did that just to see the integrity of the vertebro-basilar system. Oh, lo siento, senor. A little bit of pain in the groin there, going with a large sheath. So we went ahead and did a CAT scan angio. The CAT scan angio went ahead and showed us a patent left vertebral. And for those of you out there who don't know, the left vertebral is most of the time the dominant vertebral. And then we went ahead and also assessed the subclavian artery, not only by CAT scan angiogram, but also by, go ahead, walk the dilator around, and also by ultrasound, no, this thing is out. Ultrasound at Mount Sinai Medical Center. So clearly we have a patent vertebral artery, and thereby contributing to our symptoms of steel. which also produces the dizziness that she's getting. But also, more importantly, in this particular reason, the reason for intervention is really anterior ischemia. I'm going to go over the angiographic findings now, as Dr. Wiley.
The important thing to distinguish here that Dr. Krishnan is saying, and say it very clearly for our audience, is that we need to know if there is a vertebral antegrade flow or is a retrograde, a reversed flow. Essentially, if this is a stenosis of a grade maybe 80%, 75, 90, or is this a subtotal stenosis that already associated with a subclavian steal syndrome via a reversal of the vertebral flow through the circle of Willis. That is very important because in this case we have a very high gradient, 100 millimeters of resting gradient, and probably even higher, not probably, certainly even higher when the patient exerts her left arm. Have there been any more symptoms, exaggeration of the symptoms, George or PK, regarding exercise of the left arm of the patient having angina more so when exercise heavily the arms or something like that? Is that a characteristic case in this case or not?
She's actually she's mostly right-handed. However, when she does do housework, sort of like taking things out of the closet or the kitchen cabinet, she does complain about some left arm sort of fatigue beyond what her right arm would feel. So there are some symptoms there.
Mm-hmm. And it's also important, again, the handedness that Dr. Fernand pointed out is extremely, extremely important. Obviously, if it was a right-handed person or a left-handed person with this kind of symptomatology, with this kind of stenosis, the symptoms would be a lot worse. But we've treated innominate artery and subclavian artery stenosis on the right side, and obviously the symptoms are a lot worse because usually most people are right-handed. But let me get right to the angiographic findings here, and I want to start with the technique of how we do things so we get it right. Obviously, access in the groin. I don't know if you can put up the thing. As you can see, we did a aortogram here, arch aortogram, which is really not showing up very well on the. It seems like, let me see on this one. Here we go. Maybe this one will show up a little better. There it is. So you can see here, we did an arch aortogram, and it's it's essential for everyone out there who's going to attempt this type of intervention to start with an arch aortogram. I know you've got one at the level at the time of CAT scan angiography if you happen to do it, but it gives me and Dr. Wiley a lot of information in terms of the origin of the subclavian, the type of catheter that we're going to choose, and also whether there's any ulceration or aneurysms at the site of where the intervention is going to occur. Obviously, if you had a thoracic aneurysm associated with subclavian stenosis, it's going to totally change your management, and probably you're not going to take an endovascular approach. If you have thrombus sitting at the area of intervention, it's also going to change. Or if you have a anomalous subclavian artery origin, it's also going to go ahead and change your approach. So it's extremely important to get that pre-imaging prior to before you do your intervention. The other things we look at are obviously flow on the contralateral vertebral. Here we know we have flow because we have a CAT scan. But if you didn't, you might want to take a shot to demonstrate antegrade flow, as Dr. Dangus pointed out. The second thing here is also you want to try to get a general idea of the calcification, and I want to go to a more selective view. The catheter we use for the selective view is what we call as an aquatempo vert-tip catheter. It's a catheter made by J&J Cordis. It's a 125 centimeter catheter with a nice stiff tip, and we're able to really easily cannulate the subclavian artery. At this moment, it's not essential that you really need to worry about what catheter you use. Obviously, it's not a chronic total occlusion. If it is a chronic total occlusion, you may want to use a VTEC catheter or maybe a more aggressive catheter to be able to give you a little bit more support, and then back it up with a 90 centimeter sheath. Once we did that, we went ahead and crossed this lesion, and surprisingly, it was quite difficult to cross. It was, as you can see here, I don't know how it shows up to yourself, George. You can see clearly Dr. Wiley's having a little bit of struggle pushing the slippery aquatempo catheter across the lesion. And we actually had to get the wire way out in order to be able to get enough support to go down.
And this is the angle glide wire? Or
this is an angle glide wire we used to cross the lesion. And obviously, we took great care to avoid the vertebral as well as the LIMA.
I should say, just to clarify for the audience, this was a stiff shaft angle glide wire.
Exactly, a slip shaft angle terumo wire. And then Dr. Wiley was able to push this catheter distal to the LIMA all the way down into the axillary artery. Then what we did was we then went ahead and went with our supercore wire, which is actually currently, as I go live fluoro, is out in the axillary artery or near the axillary artery. And we have a 90 centimeter pinnacle sheath all the way up. And we went with a 7 French sheath here because of the fact that we have a calcified lesion and there's a risk of dissection or rupture or whatever it may be. We wanted to be able to have the ability to deploy a covered stent if we needed to.
Now, what is interesting in this case is that, again, we find a very characteristic history of this patient, the significant smoking history in patients with subclavian or branch aortic disease, I should say. The other interesting thing is that for the most part, these lesions involve somewhat the ostium. This case seems to be a little bit higher up. It seems to clear 5 or 8 millimeters from the ostium of the subclavian.
Yep, and
technically, the important thing is that the lesion is clearing the vertebra very nicely. This is a very important interventional part that PK can play back the previous angiogram, or we can see it's very important that we're not bridging or including the vertebra within the lesion, because that's going to change our interventional approach quite a bit, or even make it not such a good choice. But here we have a clear, again, 5 or a few millimeters from the from vertebra, which is the first branch of the subclavian. Let me remind people of this relationship.
Now, George, what we decided to do here was anticoagulation. We went with bivalirudin. You can obviously go with heparin or bivalirudin. Safety has been shown. And we've been able to actually do most of our interventions on bivalirudin. So here what I did was, there are certain views that are essential in subclavian artery intervention. And one of the views that we use very, very commonly, and is used not only by us but everybody out there, is the RAO cranial view. And if I'm going to ask Ray to toggle this image so we can show you a little better, the lady's obviously breathing, but you can see in an RAO cranial view is that you can see both the vertebral artery above, and you'll see the LIMA shooting down below. There's a good image of the vertebral artery. I don't know if you can see it, which is very, very clear. Now go forward, right?
Yeah, we do see it.
And then you'll see as you see LIMA will come at the end. Keep going. Keep going. Oh, I think the other way, right? Yep. So you'll see now the LIMA will shoot at the end. And right there, you kind of see it. Keep going forward. There it is. You saw it? So we're going to take a better picture really to demonstrate our LIMA.
Yeah, we see this right there for practical purposes. In this case, I mean, the normal anatomy, the LIMA comes right distal to the vertebral. Yep. So unless you demonstrate that this is a reverse or a ectopic or something like that, then, if you see the vertebral, you're sort of safe. Right. You also don't cover the LIMA, but
Signora,
particularly in this case, we have to be very careful, because this is done for a LIMA patency.
There you go. That's a better view we took here. We actually moved the catheter closer, and now you can see here, you've seen the vert and you've seen the LIMA.
Yeah, exactly.
So now what this does is it helps you decide on the landing zone, and it also helps you to decide, what type of stent you need and how much proximal edge you have. So now what we're going to do is, since we had a lot of trouble advancing our wire, just our glide wire and our catheter, we're going to go with a really, really small balloon here. We're going to go with a 4mm 20 balloon just to make a little bit of space. And then I don't want to, we were initially going to go IVUS, but since we had this difficulty crossing this with a catheter, I'm a little worried about losing wire position and mucking around with a 014 wire. So I think here what we'll do is we'll go ahead and we'll go ahead and do a balloon angioplasty to make some room, and then we'll talk about what we're going to do. Hang on a second here. So I'm just going to go with a 4mm balloon. Dr. Wiley's giving me a rail, and the behavior of this balloon is going to tell me a lot. It's going to tell me how everything is going to go, because obviously the stents are much more bulkier than the balloon, and so you definitely want to be able to learn. See, it's pulling back already. So the question is, what's going to happen?
Oh, what's the wire?
So, we're going to be careful with that wire. So the question is going to be whether we need to get this wire further out or what. And if we do...
Sounds like the wire needs to go to the arm.
Yeah, it's probably going to have to, George.
Distal.
And I think that's what we may have to do.
Unfortunately, there's a little bit of a branch of the subclavian that the wires tend to both... We saw it in the glide wire positioning as well. There's kind of a natural course of a wire.
We'll walk this wire out. Walk the balloon out. So what we're going to do now is actually get the wire distal as much as possible, but taking the aquatempo and really going on the stiff part of the wire, which we should have done actually earlier, because if you saw the way the wire behaved, clearly there's an issue. So, and again, there's another reason, to learn from as you do your intervention on the characteristics of the lesion. So we're going to now go back with the aquatempo and really place this quite distally. So while Ray gets the aquatempo ready.
And I must say, PK, that although angiographically and with the subtraction angiography, we see the subclavian lesion of this patient and many other patients rather straight, there is always significant tortuosity right after the takeoff of the subclavian. So this lesion seems to be exactly where the subclavia kind of twists and makes a turn towards the left side. And it is not only just a lesion, a significant calcification in this patient who is a heavy smoker, but in addition, on top of that, we also have the tortuosity and the twisting of the subclavian vessel, making things a little bit more difficult for crossing.
Show me. So you can see here the soft part of the wire is out, so we're going to be very gentle in trying to get this through. And I just want to get a little purchase with this catheter first. And once I get a little purchase with this catheter, maybe a little bit of twisting motion, a little bit of herky-jerky to get it through.
Yeah.
Now I'm going to go ahead and get this wire as distal as possible. So now I'm just going to advance this wire, and Dr. Wiley is going to follow the wire into into where it's going to go.
Yeah.
Show me a little lower.
Even further.
So can you twist the table, Ricky, so I can see the wire distally? So it's important again to do certain complex interventions. You want to the other way. You want to go ahead and see where the wire is going into the brachial.
You can go lower magnification, Jose. We can see better.
So this is actually quite good. We're way distal now, so I'm pretty happy with where the wire is.
Yeah.
Go AP again, Ray. So now we're going to show you where the subclavian is now, which is right there. And now you can see we got the stiff part of the wire there. Now I'm going to remove this again, and I'm going to go with the 4 French once again.
With a 4 balloon.
Yes, 4 millimeter balloon, pardon me.
And again, this balloon is a peripheral balloon. I'm saying that because there also exist 420 corner balloons over 0.014 wires. This is going to be a peripheral balloon that is able to go over a 0.035 wire, which is the stiff supercore that you see here.
Right, and this is part of the limitations of what we deal with, as you know very well. To be able to work with really bulky equipment, sometimes even though the vessels are large, lots of calcium and other things really work against you. But and all the techniques like taking a deep breath and things like that, things we use in the coronaries, really don't work in the peripheral. So fortunately or unfortunately, we're dealt with with the cards that we have and the equipment that we have. So what we try to do is get the wire way out like we have now, and obviously we're going to be on the stiff part of the wire. And now I'm just going to try to advance this, and trusting my partner, Dr. Wiley, to give me a rail, I'm going to go ahead and advance this through that lesion. And it keeps getting stuck here, but we'll pull it up. We'll get it through. So you can see here, a little bit more support, we're able to get it across.
Yeah, this went very nicely. Again, this goes through the stiff part of the wire that has encompassed the entire curve of the subclavian.
Exactly.
So now it's really the appropriate rail. So we're going to do a little bit of a testing there.
Yes, we are, George. We're going to go up with a little bit of a test.
Lo
siento, senor. A little die, guys.
And you see how it takes the...
We still got a way to go here. So we're going to try to just slide it forward like right about there. Now we're going to have her take a deep breath. Senora, no respire. No respire. Inject. So it actually has come back a little bit. So you can see it's pretty far up, close to that vert now.
Yeah, it has come. We'll probably need to go a little bit further in, but I wonder if you could also take a more selective view with a guide inside the subclavian so we can see more clearly the vert. They did not project well
Respire
in our
normal,
screen.
senora. So I'm going to have her take a deep breath again. Senora, uno vez. Respira profundo. No respire, no respire, no respire.
Fortunately, she's still breathing.
She's still breathing.
The guide is also a little bit, every time she breathes, the guide goes a little bit away also.
Right. So, I am going to advance this a little bit forward because I do need to go ahead and balloon this. So I'm going to go forward a little bit now. And you can see here, a little test ray.
Tell me when
You got to advance your
I'm just going to go up now.
In,
I'm happy right there, George. I'm going to go up with this. We may be slightly across the vert, but I think that should be okay. And here's a 4 millimeter balloon going up. 6.
So look,
What's nominal? So
no.
we always go to nominal.
If this is a 20 balloon, and according to how far inside the subclavian it sounds like we're going to need at least
on,
a
this
30
side,
millimeter long stent. And this is another useful measurement one does with using of this balloon, not only for size but also for length.
No te mueva, señora. No mueva su cabeza. Pull it back the balloon. So we're going to walk the balloon back. We're going to keep the balloon in the guide. Señora, aguanta la respiración. Aguanta, aguanta. And you can see with the injection, you can see that we have opened up a little bit of a channel to be able to get in. So now we have the vert, and we have a little bit bigger channel here.
PK, maybe she's breathing too much. Maybe you want to switch to the coronary next from
now
on through the because we can't really see very well here.
You got it. You got it. So let me get a 6 millimeter balloon, guys. I do serial balloon dilatations here, George, because I want to be able to really expand this balloon. I know I got a 4 down, but I had a lot of trouble pushing a 4 in.
Now, are you planning to take a balloon expandable or a self-expanding stent? That's one of the very critical questions we have to ask in vertebral interventions. If it was osteal, I would say 100% a balloon expandable stent. Since it's not osteal, well, what do you think? It could be both.
It could be both. I think you're absolutely right. But the level of calcium and how this balloon, how this expands, is going to tell us a lot. You know, it's a heavily calcified lesion, and I still haven't fully expanded it.
Yeah.
I did a 4 millimeter balloon in order to be able to get my equipment across. Now I'm going to go ahead and go with a larger balloon, a 6 or a 7 first. First I'll do a 6 and then a 7, and really get an idea of how this is expanding. If this expands really, really well, and all of us in this room are convinced that we've cracked the lesion, then I would go ahead and go with I could go ahead and go with a self-expanding stent.
The vertebra seems a little pinched here, but I must say that we have a suboptimal picture because of the breathing. But this is another consideration as we do these balloon inflations. And
well, obviously, you definitely do want to get the ability to be able to land it perfectly. You know, you want to be able to avoid that vert. I mean, you are going to get a little bit of overlap, as you know very well. You know, there's no question that went much easier. And because of that, you're going to have to deal with a little bit of a pinch, and that's why we do what we do in terms of the CT. Give me a coronary now, guys. So now I'm going to put it on coronary, so this way there's no more
could you please
breathing.
Advance the sheath a little bit, because we get a more selective picture that way.
Yeah, she's having a lot of pain in the groin. All right, ready? Picture. Inject. There you go. So you can see the competitive flow in the vert now. So now I'm going to advance and you can see the level of calcium as well. So now I'm going to advance this balloon, guys. Real. So we're going to advance forward. Okay. I'm going to have to go up there. I know it's across the vert a little bit, but we're going to go up. We definitely do want to expand this. Respira normal, señora. Respira normal. You can see it going up. Dolor or no? No dolor. She's sleeping very, very nicely. So now we're going to go up to 6 again.
Another useful function of that's already looked very big. I will not go more than 7 in this 7 stent in this lady. This seems already to be a very big balloon. Anyhow, I wanted to say that another aspect of a CT angiogram is the fact that we check the contralateral vertebral. Can you talk to us a little bit about the right vertebral PK in this case? And by the way, it would be good to put the sheath sometimes over the balloon.
Okay. So now what I did was as if you've noticed, I was able to telescope the sheath in through my using my balloon as a scaffold or as a dilator. So now I'm more selective, and you can see by the injection I've got the vert, and I've got my my LIMA obviously much more distal, which I'm not so concerned about. So now at this stage now, it's a judgment call, George. I really believe that you want to go ahead and say to yourself, hey, what do I want to do? Do I want to go ahead and put a balloon expandable or self-expandable? For me, with the level of calcium here, and with the fact that we have to be precise in our stent placement, I'm going to elect to go with a balloon expandable stent at this level. And also knowing, even though subclavian disease is classically aortic plaque extending, there's absolutely no gradient at the level of the ostium here. Yeah, so exactly. we may elect to miss it, or we may elect to cover it. I think I'm going to let Dr. Wiley make some comments as we walk this balloon out, and we'll also ask Dr. Fernay his thoughts. Go ahead.
Yeah,
Walk it out and talk.
as Dr. Christian has said, it is important to choose what type of stent we're going to be using. If it was an aortoosteal lesion, definitely we will be using a balloon expandable stent. If we're close to the vertebral, we will also want to use a balloon expandable stent. Otherwise, a self-expanding stent will be appropriate. There's always concerns of stent fracture, for which self-expanding stents obviously have a benefit, particularly when the lesion may be close to the crossing of the clavicle. Otherwise, a balloon expandable stent is more than appropriate. And I think in this case, in order to be precise, a balloon expandable stent would be probably the best choice.
If the so this was a 6020 balloon, are you thinking of a 727 stent or something like that?
I'm thinking about an 8, George. And ideally speaking, for everybody out there, you should be measuring. We have the luxury of the CAT scan as a measurement, and by CT measurement, this came out to be about around 7.5 to 8, or 7.7 in certain areas. So I think if we go up with an 8mm stent, 8027, like George said, I think it may be a reasonable stent to go with. We could go with the 7 and then post-dilate to an 8. That's also easily something we can do. But as you know, when you post-dilate, the stent is going to shrink. So you may lose a little bit of length, and you may have to add a second stent. I think here, in our experience, an 8mm stent, I'm going to discuss with Dr. Wiley, obviously, see what he thinks, whether an 8mm stent or a 7mm stent, and then we decide. We know that the CT measured it from 7.7 to 7.9. So as we go up with the stent, we can go to profile, see how it looks, and then decide whether we need to go up any further. The other advantage of the balloon expandable stent that's been talked about numerous times, obviously here, is going to be the actual ability to be as precise as we can be. So what do you think, Dr. Wiley?
Well, if you look at the proximal portion of the subclavian, I think is perhaps a 8mm, and right at the level of the vertebral is probably 8 as well. You look at the image of the balloon inflate. I think an 8 will be appropriate.
So we're gonna go with an 8027. The stents available. We use the VisiPro by EV3 stents. There are obviously multiple balloon expandable stents, and this stent has a good radial strength, as does the Boston stents and the Abbott stents and the Medtronic stents.
Now we have a question from the audience, PK, and probably it's based on previous picture showing some vertebral pinch. And there was a question, are we concerned about the vertebral stenosis? I think subsequently this has resolved, but I want to ask you the second question that is here. Are we concerned about embolization of materials in the vertebral, and when might that be more pertinent than other such cases?
Well, you're absolutely, I think distal embolization is a problem with everything that we do, as you know very well. And I think, that the reason to put a filter in a vertebral hasn't really been defined. There are people who do it, and in our experience, vertebral filter placement has been associated with a lot of spasm. Now, having said that, you could get a brachial access here or radial access here and put the filter if this was the only vertebral that was supplying the brain. You could use a Percutaneous filter or any sort of softer balloon occluding filter in there, or you could use a regular filter wire up in from the brachial access. The reason why I'm suggesting brachial access in this case is what you need to do is to take into consideration the difficulty that you had to advance a balloon and now with the difficulty you're going to have to advance the stent. So because of that severe calcification, you're going to have tremendous difficulty in terms of your ability to advance these things. So if you have a 014 wire on a filter wire, there's no way you're going to be able to deliver this bulky balloon expandable stent on that filter wire. So you would have to think ahead of time and say to yourself, okay, well, I am going to protect this vert. I am going to do this. As you know, embolization does occur in everything, but here, hopefully, because of that angle and the tortuosity of that vert, osteally, it would be less likely to occur. But I don't think we're able to predict these things, and I think that's a great question. And I really believe it. Can you rail me, please?
Now, in another aspect that addresses this question is the following: after the first balloon inflation with the 4.0 balloon, there was a flow limiting dissection, and at that point, we saw that the vertebral flow had reversed. So one can say very credibly that in this particular case, when the balloon occludes during the stent inflation, the vertebral flow will also reverse. and therefore they would have a proximal embolic protection established anyhow. So we will need the flow in this case. Let's go now to the placement of the stent. You saw that this stent navigated extremely well over a wire through the lesion. And PK, what type of stent is this again? Is it a protege?
This is a 7.0 VisiPro. It's a self-expanding stent. Now, what? Excuse me. It's a balloon expandable stent. Pardon me. One of the things, George, is that I really want to get across to the audience is when you drag these stents back and forth across these lesions, there's a chance you may lose the stent. So you have to be extremely careful on how, when you're trying to pull back and forth on a tight lesion. Now, we moved it across. I think I've got it in the right position. I just want to make very, very gentle movements here to be able to go ahead and place the stent where I like to place it. Yeah. So right now, I'm going to ask Dr. Wilder to give us a little test here. So we're going to give a little test. We need to go forward slightly. So I'm just going to go with a gentle movement. So no te muevas, señora.
So the important thing here is to nail the vertebral. That's all we notice in this particular case because
that's pretty good.
Because in the ostium is not a significant disease. So we really need to nail the vert.
Yeah, it's going to be very, very quiet to do. So we're going to take a shot here to see, and you can see here we probably have to come back maybe a cell or so. So we're going to save this on this right side for me, Ray. And you can see we're plenty long enough. So we're going to come back maybe a cell or so, and then we're going to have Dr. Wiley give another test here as I come back. Little die. I think I'm okay there.
I think it's excellent.
Yeah, so we're going to take this for the distal placement. No. And so now you've seen exactly where we are in terms of the vert. Now I'm going to have Dr. Wiley go to the two views that are important, and I think as part of the teaching of this case, one of the two things that we want to see is exactly, why can I move my C-arm, guys? Okay. I want to tell you how to hit the ostium. So the two views you want to look at when you look at the ostium, even though this is not a case for aorta ostial subclavian stenting, I think it's important as part of our teaching to show these two views. So one is the RAO cranial here, inject. You can see here, if you're trying to hit the ostium, you need to come back. But I want to demonstrate how beautiful it is for you to be able to see the extension of the aortic plaque into the subclavian.
So this is areocaudal.
This is areocaudal, and you're able to see it. And the other view that you also need to always look at before you do ostial subclavian stenting is laeocaudal, and you'll see it here. Multiple different views for you to be able to see the ostium. And again, I'm going to have a little bit of injection here for you to see. So we're going to inject here. And you can see here, the subclavian also helps you where to land with the subclavian and with the vert. So I'm actually going to stent it in this view if it's okay with Dr. Wiley.
I agree. I think it's excellent because you kind of see both.
You kind of see both, and you're not really trying to cover the ostium here. Although people could argue there's a little bit of a minor stenosis, and I think we're going to get a lot of comments on that. To me, you could go with a 37 and nail both. And I'm going to discuss that with Dr. Wiley, whether we need to upgrade this, or I think you're okay with leaving it.
No, I think we're okay here. It's not a aorta-osteal lesion. I think that will be more than appropriate.
Some would argue that all subclavians are aorta-osteal lesion, but I think here, because we have a CAT scan showing there's absolutely no aorta-osteal stenosis, and we have obviously gradients showing that, and now we have a stent in place already, we're going to go ahead and have Ray just give us a little test, okay? And then we're very happy with our placement, okay? Senora, no mueve. Give me a little die again. Ray kind of moved a little bit now. See, it moved. Okay, it's coming down. It's good now. Okay. Do you like it? Mm-hmm. Everybody like it? Okay, let's go up slowly. So we always go up very, very slowly, George, as you know, in our lab. So we're going very slowly. Obviously, we're occluding the subclavian now. I mean, the subclavian flow.
And now, see how big it is, the 7. I think it was a very good size, 727, and you see now you can see where the tight spot of the lesion is, and we're kind of covering 2/3, 1/3 that spot very appropriately. We have nailed both the proximal and distal reference segment, and I think.
So now, George, we went ahead. We've inflated the stent, and now we're just going to test a little bit to see if we perf. She had a lot of pain. Little die, guys. And we can see there's no clear perforation that's occurred. Now, that's actually a very, very good point that I want to make, is that one, we've got hemodynamic monitoring of our blood pressure, showing that our blood pressure is stable. The second thing is we've got a balloon across the lesion while we test it. Third is we recognize that the patient had pain and didn't go up further with the balloon. Now, for the coronary interventionalists out there, I know the vascular interventionalists and the radiologists know this better than the coronary guys do. When you go up with these peripheral balloons, you want to go up slowly. You want to go 1, 2, 3, 4, not the way we do it in the coronaries, up and down, because these vessels are obviously free floating and also can have perforation because of the severe calcification. Plus, as you go up slowly, you'll learn from the patient. So the patient, when she says, ow, that means that you're stretching the muscle, that you're stretching the vessel wall.
Yeah.
Number two, if she becomes bradycardic, you're actually stretching the adventitial plexus in the adventitia and causing her to vagal. Excuse me. These are clear indications of impending perforation. So you want to be extremely careful in these patients to make sure that you're there. So now that we've balloon inflated, I'm going to go ahead and pull my sheath in a little bit. I'm going to have Dr. Wiley walk this out very, very slowly.
Given yeah, it's a very important technique. Now you see that the sheath is going a little bit in the subclavian over the balloon in order to be able to take high-grade selective pictures as well as to advance further equipment if needed. As you see here, we may need to have a little bit more expansion, maybe even with a 6 or something balloon in the middle there, but we'll see about that. Anyhow, the question I wanted to ask, and we have one from the audience as well regarding that, since you sensitized us regarding a perforation, what is the role of a covered stent in a situation like this? For example, could we have used a PK, the atrium stent, in this case, that would have no risk for perforation?
Okay. Well, you have it's a great point, George, and there's a lot of questions about whether we should use the atrium stent or not. And in our experience, what we feel is that the radial strength of the atrium stent is not going to be as good as these other stents that we have. Number one. Number two, covered stents in the sense, when you're trying to do precise intervention, I know you can be precise because it's a balloon expandable stent. God forbid you do miss, you're going to cover the ostium of the vertebral or the LIMA. Number three is, as far as the rupture is concerned, clearly, God forbid you do rupture, but as we demonstrated in this really, really calcified lesion in the subclavian, it probably can be done safely without any issues of perforation. Now, as far as this gradient that we're concerned about, now this is an 8mm stent. We went with an 8037.
Well, it was an 837.
Yeah, it was an 837. And you can see placing minus that we have a nice
827.
We have a nice expansion plus. That we have a nice expansion and we have a little bit of a dent. Now, you could go crazy and go ahead and balloon it, which we may, and I think we'll discuss that. And or we could check a gradient and see whether we have a gradient, and if there's no gradient, we're done. I think that's what I'm going to do.
You may, if you consider dilate, have considered to undersize a balloon and dilate it with a 7, let's say, since you have a.
You absolutely could.
Or to use your 6 balloon again.
She had that.
Yeah. Can you give me a straight tip catheter? One of the things that I want to stress to everybody is that unlike the coronaries in the endovascular space, we're treating gradients. We're treating pressure differences. So yes, you may have a lesion, a stent that you would not accept in the coronaries because of this dent, and there's been no the stent thrombosis data associated with this in the peripheral as far as I'm aware. So the bottom line here is I want to eliminate this gradient, which was 100 millimeters before, to now whatever it's going to be, and then we're going to make a decision. We know that gradient produced significant LIMA ischemia. We saw the flow was extremely poor both in the LIMA and the vert. Now in our post shot here, you can see a robust flow in the vert, robust flow in the LIMA with a wonderful placement of this stent. So I'm just going to go ahead and check a gradient, and obviously I don't have 2 transducers, but we'll try to do our best. Let's see whether we can get 2 transducers set up, guys, while we do this. And then we'll go ahead and decide what we want to do.
Yeah, could you in the meantime, while you set the transducers, could you also take pictures in these additional views that we used before, so we can judge how it looks, particularly the REO projections?
Sure, absolutely. I think that's a great point because you could be foreshortening that stent, although I doubt it. It looks quite good in this view. And what we're going to do here is we're using another aqua tempo straight tip catheter. And we're going to go slowly across this stent. You can see our sheath actually retracted back, which is okay. We know we don't have a perf. And we want to be extremely slow as this catheter retracts forward. Is the wire coming back, guys? No. So we want to make sure. And now we're just going to jimmy it forward like I just did there. Show me the wire, guys. So as you know, now we're going to go way out here. and now we're going to pull this out, the wire out. Now we've actually lost wire position distally, which is okay, because we've got our supercore ready. We know we don't have a perforation, and now we're going to go ahead and do a picture that George wanted, so this way we can demonstrate to you exactly how this is. Watch your knees, guys. Okay. All right, Ray, DSA, please.
Yeah, could you? Yeah, good.
So, señora,
This is the
aguanta la
REO,
respiración.
This is the REO 44 cranial 15 picture.
Aguanta, inject. Sorry. Okay, everybody got sprayed by me, and I apologize because the catheter is obviously big inside this sheath. And you can see here, it's actually extremely well placed.
Yeah,
you have a
excellent.
beautiful balloon expandable stent. You know, in this view, I actually wouldn't even post dilate. We have no real pinch to that vert, and I think it's more a little bit of nothing, just an angle. And the LIMA is very, very robust. So, I mean, I'll check a gradient as we talked, and I've got dual transducers now. We're going to zero both in a second. Let me just do this.
I think we should be cognizant of the fact that she had a little bit of pain when we were deploying the stent, so the risk of perforation may be significant if we try to post-dilate. The restenosis rate of subclavian stents is quite low. So
is she still smoking, by the way? If this
actually, we can't come forward.
That is a significant risk.
Actually, she stopped. I just heard from our nurse, Elizabeth, that she's totally stopped smoking, which is a wonderful sign for us, which shows that it's obviously going to increase our ability to show that the patency is here. Now, if you can show the transducers, the dual transducers on the screen, we're asking our cameraman here to just show the screen. And can you show the screen, guys? And the hemodynamics. And we actually have both the, there you go, we got it now. We actually have both the transducers, the red being in the aorta and the white being in the distal subclavian. And you can see here, because of her sedation and other things, she has absolutely no gradient across this subclavian artery. So, you know, having done this, having a quality 2 projections showing what it is, the fact that she had pain, and the fact that post-dilating it may actually cause harm, I think what we're going to do here is probably call it quits, George.
No, that is absolutely acceptable, except on the second view. You didn't really have much of a dent. I would definitely not post-dilate with an 8mm balloon. That is definitely going to be way too much. You have a 6mm balloon in there that you can use if you want it at a very high pressure. I don't think that's going to cause a problem with perforation.
Right.
But given how this view, the second view looks now, I'm also underwhelmed about post-dilating.
And I think, you know, we have a very acceptable, we have no gradient, so we resolved our problem. We did it safely. We did it on the angiomax. You know, she had pain while we did the actual balloon angioplasty that gave us a sign. You know, she's having a little bit of tenderness in the groin, and I think here, you know, we're 10 minutes under our hour, which is great. And, you know, I think it was a nice demonstration of a pretty complex lesion with heavy calcification, taking into consideration the vert and the LIMA. And I really believe I'm just going to call it quits here and say thank you very much to you, to obviously Dr. Fernane, to the patient, Dr. Wiley, and my team here. And, you know, obviously this case will be archived. And we're going to go over the approach to upper extremity and brachiocephalic disease in our lecture right after this.
Great, thank you, Prakash, Jose, and George from the Cath Lab. Again, anyone who wants to send any comments, we'll continue to address any emails at info@peripheralvascularinterventions.org, and we will see you all again April 25 with another endovascular case for the cardiac catheterization laboratories at Mount Sinai Hospital, New York City. Thank you for attending.